Dear audience, we have next speaker, Dr. Budi Wiweko, who is coming from Indonesia and is a faculty of medicine to universities of Indonesia, working in General Hospital, Jakarta. So may I invite Dr. Budi Wiweko, who is going to talk on AMH.
Thank you. Thank you very much.
Oh, sorry, one more thing. Just after Budi, we have got Luhi Hal and then the orations. Yes.
Thank you very much, Madam Chairperson. Good afternoon, everyone. Good morning, everyone. And thank you for inviting me. Thank you, Dr. Pai, good friend of mine, and also the Nandita and Amit and Sujata. It's really a great pleasure for me to be here in the very great ISA Congress 2024. So just continuing our discussion this morning regarding the rejuvenations in reproductive medicines, I think we know very well right now if we talk about the agings, it's very important for us, especially for the reproductive medicine field. It is because of most of women have only 12% of their follicle pool remaining at age 30 years old and then falling suddenly up to 3% only at age 40 years old. And we know currently AMH is still a good best biomarker to predict oocyte quantity, but still a big question if we want to predict oocyte quality looking at the serum AMH level. And then this is the concept of ovarian aging. We know that representation of age-associated changes in the ovary and the mitochondria, and then the aging process alters not only the ovarian reserve, the quantity, but also the oocyte competencies, which is quality. It's much more important. And we know that mitochondria demonstrated parallel changes, not only quantitatively, but also qualitatively. And we can see in these figures how in the ovarian aging, oocyte apoptosis will increasing, and then oxidative stress, mitochondrial dilation quantitatively will declining, and also mitochondrial mutations. It is happen in our aging patients. And very important if we think about mitochondria, so due to insufficient energy supplied by mitochondria in aging women, so that's why many fertilizations alters by insufficient energy of mitochondria. So that's why higher prevalence of aneuploidy. I think previous speaker talked a lot about how we do genetic screening in IVF. So it's very important in aging women, increasing of the aneuploidy embryos. It is happen because of insufficient energy, because of lack of mitochondria. And we know the first concept of three parents IVF by John Zhang because of mitochondrial transfer, mitochondrial donations. But right now, people trying to establish autologous germline mitochondrial energy transfer we know as the augment treatment. During the augment strategy, people trying to isolate the precursor cells that related with mitochondria. We identify with the use of DDX4 gene expressions from the ovarian cortical tissue, and then trying to isolate, and then togetherly, concurrently, the mitochondrial stem cell or DDX4 was injected by ICSI, and then hoping that by injecting mitochondria together with sperm, it will improving insufficient energy, so people will get a good embryo, the good quality embryo, to be frozen or to be replaced to the wombs. And then our study in Indonesia also trying to see what is the effect of AMH to expression of mitochondrial DNA in the granular cells. So we're trying to see how the correlation between mitochondrial and the granular cell with serum AMH. We know very well that there is a decreasing at least 0.4 copies of mitochondria annually. And then this is the also quite related with the number of serum image level. Yeah, this is we can see on the figure A, B, and C. If we look the number DNA mitochondria copy number according to the number of the group of normal weight, overweight, and obesity, there is no significant relationship. There is no significant difference the number of DNA mitochondria between three groups. And also if you compare the groups with supplementation of LH and the growth hormones, there is no significant difference of DNA mitochondria expressions in the granulosal cells in IVF. However, if we look the expression of DNA mitochondria in granulosal cells is quite related with the age of the patients. By getting older of the patients, expression of DNA mitochondria in the granulosal cells also is lower. And also serum image has the positive correlations with the number of DNA mitochondria in granulosal cells. That's why it's quite interesting. Yeah, if we talk about the aging, not only the chronological age actually, but also biological aging is very important. Even the young women, but if the image is quite low, of course, then DNA mitochondria also is lower. And people, I think right now it's very interesting to see how the role of intraovarian PRP autologous injection toward ovarian aging. Then I think it's one of the good study trying to see how the effect of PRP injections in the 4 subgroups in the poor ovarian response, in the POI, premature ovarian insufficiency, in the perimenopause, and in the menopause women. How do they differentiate between the 4 groups? In the premature ovarian insufficiency, in the poor ovarian response, they perform at least PRP injection 2 months following the last ICSI and ET cycles. And then for premature ovarian insufficiency, the age is below than 40 years old. Amenorrhea at least 4 months. If it is more than 25 IU, then for perimenopausal age more than 40 years with menstrual cycle irregulars. And then for the menopausal group, the age between 45 until 55 years old with FSH level more than 30. And then we can see here, this is in the poor ovarian response group, number of subjects 30. We can see how the difference prior to ICSI cycle with the first, second, and the post-ICSI cycles. And then we can see this one, the good quality embryos significantly higher compared prior to ICSI cycles. And also the cancellation rate declining then half until 30%. How about in the premature ovarian insufficiency? They differentiate between PRP success and PRP failure. And then we can see follow-up until 3 months. At least, this you can see the image level 0.75 compared to 0.18 prior to PRP injection. And then also AFC is 2 compared 0. This is in POI groups. How in the perimenopausal patients? Again, I think almost the same. Follow-up after 3 months. You can see significantly higher increasing of image level. Very significant, until 1.4. And then the number of AFC around 4, starting from 1. I think this is after 3 months injection of PRP. And then in the menopausal group, between 45 to 55 years old, even you can see still very lower than perimenopausal, but still image level in PRP success 0.6, with number of antral follicle counts is about 2.3. So according to this result, if we look actually how long we should observe, how long we should make an observation after we did intraovarian autologous PRP injections. I think normally on approximately this data showing us between 30 to 90 days. It means between 1 to 3 months if we look the concept of folliculogenesis, the growth, the follicles, parental follicles class 2 between 5 until 5, going into antral follicle, it takes about 65 days. So that's why within 65 days it's very important the role of PRP to have an effect. I think this looks promising. Even we need a lot of many evidence to convince how the role of PRP in POI patients, in poor responder patients, perimenopause patients, and also menopause patients. We can see here how the concept of PRP can rejuvenate ovarian aging. There are two hypotheses. Number one is that PRP will activate dormant follicles to develop and getting mature. This is the first hypothesis. Even it should be proven by many evidence. And then the second concept that PRP stimulate the ovarian stem cells, to differentiate into new oocytes. If we compare this one is ovary with good ovarian reserve, and then this is ovary with very low ovarian reserve. So, and then we know that the response to each patient will be different. It depends on the number of the stem cells inside in the ovary, and also the number of residual dormant follicle inside the ovary, to see how the effect of PRP injection into ovary. And this is also our result in animal models. We make an animal models POI patients by expose the mice with platinum base. This one we can see this is serum AMH, this is estradiol and serum FSH. This is after the mice becoming menopause, and then after we inject PRP injections, serum AMH getting lower, and then AMH is increasing, and also estradiol. And we can see how it works. We can see that after we inject PRP into ovary, there is increasing of FOXO3 expressions in the ovary. FOXO3 is very important to keep follicles becoming dormant, to keep the follicle from burnout process. So that's why FOXO3 is very important. And also we found DDX4 expressions in POI animal model increasing after PRP injection. So that's why we can prove the two hypotheses why PRP injection into ovary still give at least promising results. And the last, I will talk also about the endometrial problem in our daily practice. We have refractory thin endometriums. It is because of Asherman syndrome, or the worst is because of endometrial scar because of TB endometritis. I think this is a big problem also in Indonesia. I'm sure also maybe here in India also becoming a big problem. And we are trying to improving this refractory thin endometrium. This is mild to moderate endometrial scar, 3 months fully recovery from endometritis TB. And then what we do? What we do is the first we do the we try identify the characteristic of unresponsive thin endometrium. This one is a thin endometrium. This is the normal. Of course, the cell number in the thin endometrium is significantly lower. Then also we see that with the confocal microscope, this is the characteristics of unresponsive thin endometriums. The top are thin endometrium. You can see the gland and then stroma is very few compared in the normal endometrium. And then also all the expression gene regarding the receptivity. We can see all the thin endometrium is lower, Hoxa10, LEAF, SPP1, and also PGF1. What we do? So we make a special device, we call it womb pads. And then by preparing amnion bilayer, we establish medical device, and then we put the amnion bilayer into intrauterine. This is the womb applicator that we made by silicone medical grade, especially medical device, and then we do the preparations of amnion bilayer and put in the womb applicator. We call it Uterafix. Right now, it's commercially available also in Indonesia. Then the balloon will be inflated up to 2.5 cc, and then remove after 14 days, 7 to 14 days. And then we look, what is the before and after womb pads? Yeah, this one is the number of cells. This is before womb pads, and then this is after womb pads, significantly higher. The number of endometrial cells, in the uterine. And then also this one is the endometrial cell epitope, and then receptivity genes epitope. This is pre-treatment, this is post-treatment, almost improving. Even if we look the statistic, not always significant, but the number is quite promising. This is, for example, the receptivity gene SPP1, it's much better. Then if you look the histological morphology, histomorphology of the endometrium, this one is the after womb patch. You can see that this is before. We can see the structure, morphological, the gland and stroma is more clear after womb patch plus amnion bilayer. And then the second step, after amnion bilayer with womb patch, we also adding cellular endometrium. So amnion bilayer plus endometrial cells, autologous, or amnion bilayer plus endometrial stem cells. We inflate again the medical device, and then we put intrauterine. This is, for example, is very we put for the very hard case in endometritis TB. And then this one's amnion bilayer plus cells. This is only amnion bilayer. Then the cell density increasing significantly, and also endometrial thickness increasing significantly. And then the patient who's suffering from amenorrhea in the endometritis TB, they're getting relief and they have their period after the womb pad amnion bilayer, and then womb pad amnion bilayer plus endometrial stem cell or endometrial cell or endometrial stem cells. So I think this is the very promising. And if you look this one, Hoxaten, increasing significantly after amnion bilayer plus endometrial cell or endometrial stem cells. On all others, receptivity genes also increasing very significantly. I think this is our first evidence, and we are trying to submit the paper right now. Is still under review. And then the last, this is before the thin endometrium. The endometrium, this is after amnion bilayer, and then this one after amnion bilayer plus endometrial cells and endometrial stem cell. It looks much better, the morphological and histological pattern in the endometrium. So that's why the patient can growing very well the endometrium, and then the patients now or get the period regularly. Okay, I think I come to my last slide. As a take-home messages, we know that overall aging related not only to the chronological but also biological age, which including both of quantity and also quality of oocyte. And then the concentration of granular cells in the mitochondria very positively correlated with serum AMH and negatively correlated with patient's age and also biological aging. When we know the mitochondria is energy, important energy in the fertilization and the cleavage of embryos. And then intraovarian autologous PRP injections, it looks promising because in our data, the increasing DDX4 and increasing FOXO3 expressions in the ovary, which is very important to preventing burnout of the follicles during the follicle genesis. And the last, this is our study, amnion bilayer with womb pads plus cellular therapy give promising result in the case of refractory thin endometrium because of Asherman or because of TB endometrium. Thank you very much for your kind attention.
Thank you, Dr. Budi, for your elaborate, extensive, research-oriented talk, which highlighted about how to do the rejuvenation of the reproductive system. You highlighted about the importance of mitochondria, which should be younger, and how to inject them. You also told us about the large volume of your study of PRP cases. And what we do in India is stem cell-derived homeopathic stem cells are injected, but it is a little elaborate procedure, and we also believe in using cytokine-rich serum activated serum, but your volume is quite a large study of the cases from Indonesia. And lastly, the endometrium, which is shaded every monthly, that suggests us that it has abundant stem cell, and you are using them with the patch, utero patch, which is very very interesting, and I think it is the next future of rejuvenation of the endometrium. Thank you for your elaborate talk.